So I wanted to talk about rhinoplasty today. And when I see patients for rhinoplasty, you really want to determine what is bothering them with their nose. And most people will come in and they'll say, I don't like the hump of my nose, or I don't like the tip of my nose. When you do a rhinoplasty, you have to address the cosmetic portion of the nose, but also the functionality of the nose. And so I want everyone to be able to breathe better after a rhinoplasty and at the same time have a better looking nose. And so if you look at the anatomy of the nose, it is made up of both bone and cartilage. And on the dorsum of the nose, you have the bones and the cartilage that can give people a dorsal hump. And so you can reduce that to give the dorsum a aesthetically more pleasing appearance. On the tip of the nose, you have this cartilage that makes up the tip. And so a lot of people will come in and they'll complain about their nose being too bulbous or poorly defined. And so you can trim the cartilage and put sutures in that to give the nose a better appearance. Now, with the nose, there are four main reasons why people can't breathe well. And so if you look at the anatomy, you have what's called the septum of the nose, and it separates the right from the left, the right nostril from the left nostril. And the septum can be deviated. And so whenever you do a rhinoplasty, you have to look at that and straighten that septum by doing what's called a septoplasty. You can also use that cartilage to help reshape the nose and give support to the nose on the tip or the dorsum. The second thing is you can have what are called turbinates. And turbinates are these structures on the inside of the nose that humidify air, but they can also obstruct air when you're breathing. And so a lot of times we have to reduce the turbinates. And then you have what are called the internal and the external nasal valve. And they're both structures that can collapse when we breathe or when we exercise. And so you want to evaluate those and stabilize those, because I want everyone to be able to breathe better after a rhinoplasty than they did before. So whenever I do a rhinoplasty, we have an imaging device called Vectra. And Vectra is very useful because we can simulate it's a morphing program, so we can simulate what we would be doing in surgery. And one of the things that's important to point out to patients is their natural asymmetries. And most patients have some degree of asymmetry from right to left. And so what this program allows us to do is take a mirror image of the right side of the patient's face and a mirror image of the left side of the patient's face and compare it. And if you look at this patient, you can see how the nasal tip is deviated, their septum is deviated, and so their overall shape is different from right to left. And that's important to understand because you're never going to have a perfectly symmetric result, but we're certainly going to try when we do the surgery. Now, when we do the rhinoplasty, if I look at a patient like this, her main concern is her dorsal hump and her nasal tip, and she feels like her tip hangs down a little bit and she has a dorsal hump. And this is a very common situation in rhinoplasty patients. And so what I've done here is I've done a morph of what I would hope to do intraoperatively. And you can see the dorsal hump has been taken down, the tip has been rotated up, and the tip has been refined. But she still looks like herself, which is a big concern with rhinoplasty patients because they don't want to look too different. And so the goal is to still look like yourself, but just look more refined. And you can see the difference in the dorsal hump and the nasal tip. And if we look from this view and this view, the tip is just a little bit more refined. But most patients, their big concern is their profile view or lateral view, and you can see how that dorsal hump is down. So when you do a rhinoplasty surgery, it can be anywhere from about 2 to 3 hours. It's outpatient surgery. When most patients wake up, they'll have a splint on the outside of their nose and they'll have a splint on the inside of the nose. And those splints are usually in for about a week. If I do an open rhinoplasty, there are a few stitches across this part of the nose that come out at a week. If I do a closed rhinoplasty, there are no stitches that come out because everything's on the inside of the nose. The first week, I tell all my patients they are socially unacceptable, so don't plan to work for the first week. After the splints come out, most people can go back to gentle activities, and if they have a desk-based job, they can go back to work after that. And usually by about the end of the second week, most patients are doing pretty darn well and can go back to most activities, including exercise. I wouldn't want them doing any hardcore activity where they could be hit in the nose, such as playing basketball or soccer or something like that. So with rhinoplasty, there are risks, as there are with any surgery. And the biggest thing with rhinoplasty is it takes time to heal. And of all surgeries we do in plastic surgery, I always tell patients it takes about a year to see kind of a quote-unquote final result. And so you have to be patient because the nose stays swollen for quite a long time. So when you do surgery, in the first 24 hours, the biggest risk is bleeding, and it's very normal to have a little bit of bloody drainage in the back of your throat or externally. And when you wake up from surgery, you'll have a little drip pad underneath the nose to catch that. Usually after about 24 hours, that goes away. The other things that you can see are asymmetry. There's no perfectly symmetric nose. We certainly try to do that in surgery, but there's no perfectly symmetric nose. Wound healing problems. So could you have an issue on the tip of your nose or along the scar? That's a possibility. What's called a septal perforation. So you have the cartilage that separates the right from the left, and it's feasible that when you remove some of that cartilage and you do a septoplasty, you could have a hole that goes from right to left. It's uncommon, but that could be present. And then, dissatisfaction with the results of surgery. I think the vector device is very helpful. It gives people a good idea of what they would look like with surgery, but people can have an unrealistic expectation as to what they'll look like after surgery. And then general risks of an anesthetic, nausea, vomiting, that's the most common. 1 in 4 people have that. And then, death with surgery, I always tell my patients they have a higher risk of dying in a car accident, and they get in their car every day and drive. So it's very safe surgery overall.